Hello everybody, this is Dr.Reuben here, and today we're going to be discussing a topic that is very simple. A very simple topic, but then it is something that really keeps us busy every single time we treat those maxillary molars. And these are the little challenges that we come across in day-to-day practice that really motivates us and keeps us going. So let's get started.
Today we're going to be discussing the MB2 canals, about their location and instrumentation. To understand this, first we have to know the prevalence. So if you did a literature search, you will find that different authors have given different percentages for their incidence. But for all clinical practicality purposes, you just have to believe that they are present in almost all the cases unless you have taken sufficient steps to prove that they are non-existent. But then there are a lot of practitioners who say that I have not located even one MB2 in my career spanning 10 or 15 years, and none of my patients have ever come back to me with any pain. The reason for this is that most of these MB2 canals have a separate portal of entry, but as you progress down, these two portals merge and exist as one canal. Meaning, they can have a single portal of entry and a single portal of exit, or they can have two portals of entry ending with a single portal of exit, or they can have two separate portals of entry and two separate portals of exit. Or they can be cases where there's a single portal of entry and two separate portals of exit. So, in cases where there is just one portal of entry and one portal of exit, or in cases where there are two portals of entry and still ending in a common portal of exit, even though we missed the MB2 canal, the chances that we might get away with a post-operative issue for a while is quite high. So now to locating and the tools that we might need to instrument them. The first thing to do as far as locating these MB2 canals is to make sure your axis is extended far enough mesially. You can go even as far as 1 to 2 millimeters close to the mesial outline of the tooth, because this is exactly where the MB2 canals are going to be present. Take this clinical scenario for example, where the MB canal has been located and shaped, but then there is the shelf of dentine that is present, and when you remove the shelf, you will find that the MB2 canal is present exactly under this shelf. The other most important thing as far as locating the MB2 canal is to make sure the endodontic map is preserved. We should not be too aggressive on the floor of the pulp chamber. The floor of the pulp chamber holds the endodontic map, which would give us very valuable information on where these MB2 canals are present. Take this case for example. In this case, it appears to be quite calcified. But then I've been very careful and meticulous in my axis preparation, and the map is very clearly visible. You can clearly see this line connecting the palatal canal to the MB2 canal. So if I were to go looking for an MB2 canal, this is the line where I would exactly go and search for one. And that's the MB2 canal shaped and ready for obturation. This is the final post-operative clinical picture with all the 4 canals very cleanly shaped and obturated. And that's the post-operative radiograph. Having discussed the importance of extending the axis mesial enough and also preserving the dentinal map, another important consideration is the proper analysis of the pre-operative radiograph. So when you look at a pre-operative radiograph like this, you can be very sure that you are going to encounter a very calcified scenario. So all the more reason for us to slow down and very meticulously prepare the access cavity. So this is the very same tooth with a very heavily restored amalgam restoration. And on removing the amalgam restoration, we find that all the canals are actually calcified and just a tinge of blood indicating the location of the palatal canal. Then I go and locate the MB canal in the most probable location. And then I go for the distobuccal canal. So when you have located 1, 2 and 3 on a very well clearly preserved dentinal map, you can be sure that the chances that you have missed a MB2 are very, very less. So in these cases, I can be quite sure that I have not actually missed an MB2 canal. So that's the finished post-operative radiograph. Another very important test to locate an MB2 canal, for that matter any calcified canal, is the white line test. This test generally applies to the necrotic teeth which does not have too much of vital pulp tissue present on the inside. So generally when we go down and trough the floor of the pulp chamber and locate, in the process of locating the canals, we end up depositing these debris into a lot of anatomic spaces like a groove, which leave a characteristic white line like this. So generally these hidden anatomic structures are present along these lines. So this is the white line test. So here's another interesting case that was referred to me for locating the canals, and as you can see, the entire floor has been completely messed up with a lot of debris. The first thing I would do in these cases is leave some EDTA in the pulp chamber and clean up the debris that are present. And then, if you can notice, there is a little white debris stuck in the line or the groove connecting the mesiobuccal and the palatal canal. And this is exactly where I would go look for my MB2 canal. So that's the MB2 canal located, shaped and all ready for obturation. And that's the finished post-operative radiograph. This is what the white line test is all about. Look for areas where these debris go in deposit, and these are areas where most likely you would find the MB2 canal. Next is the red line test. In vital cases like this one, which has been referred to me for location of missing canals, the missed anatomy or the extra anatomy can show up as a small bead of blood on the floor of the pulp chamber, often in the grooves that connect the existing canals that have been located. So that's exactly where I would go and negotiate to locate the extra canal. And that's the MB2 located, shaped and all ready for obturation. This is the post-operative radiograph of the very same case. Here's another vital case that I started where I've initially completely removed the caries. The pulp chamber had a lot of pulp tissue present, which I scooped out carefully with a spoon excavator. And there was one particular area where I could see a lot of pulp tissue adhering to with a streak of blood. On exploration, this is exactly where I found my MB2 canal. This is not a very typical location of where an MB2 canal would be, but then as far as root canal anatomy is concerned, there has never been a certainty on how and where we would find these things. So that's the finished post-operative radiograph of the same case. Another interesting way to locate missing canals and MB2 as well is the use of canal detectors. I routinely do not use them in practice, but in case you would be interested, there is one very interesting article written by Dr. Sachin Alapati and Gary Glassman. You could probably go and look up this thing. Another technique that can be used to locate these MB2 canals is by mentally visualizing a few arbitrary lines when we do a access preparation. For example, in this case, let's just imagine a line that connects the MB to the palatal canal, And from there, I would draw a 2 mm or a 3 mm long line on the mesial side at a 10-degree angle. The chances that the MB2 lie on this line are going to be extremely high. Another way of going about it is by drawing again a line connecting the MB to the palatal, and then a line that connects the distal buccal to this line perpendicularly, and at the point where these two lines meet, I would draw a 1 or 2 mm arc. The chances of the MB2 on this arc or on the perimeter of this arc are again extremely high. So these are two techniques where you can just imagine lines present on the floor of the pulp chamber in case you are unsure about where to find the MB2 canal. Another technique that I very routinely follow in practice as far as location of the MB2 canal is called the rule of 2. The rule of 2 means that I would go as far as 2 mm away from the MB canal and would never hesitate to dig as far as even 2 mm down into the floor of the pulp chamber in the process of finding the MB2 canal. So let's just look at this particular case you're looking at. So if you can see here, I have drilled out dentine on the floor, and you can see the MB2 canal present as a faint spot, and it's exactly where I have instrumented with a hand file and located the MB2 canal. Now let's see a video of the very same case. So what I'm doing here is drilling out the dentine on the floor with a Munz burr. We'll discuss what a Munz burr is a little further down in the lecture. So I'm digging down into the floor of the pulp chamber to locate the MB2 canal. I would then flush out these debris with saline. And if you can see, that's exactly where the MB2 is present, right down. And that's exactly where you can locate it. And this is the finished post-operative result. So here is another example of the particular scenario we just discussed. We have here a maxillary second molar with an extremely calcified pulp chamber. So even after cleaning, shaping the MB and looking around for the MB2, there is absolutely no trace of the MB2 canal at all. So on troughing further down, we can notice a faint spot, which is nothing but a groove which has gathered some debris from all that troughing present. So what I do here is I dig further down on the floor of the pulp chamber, and that's exactly where I found the MB2 canal present. So that's the MB2 canal, shaped and obturated. Note how further down into the floor of the pulp chamber it is present. Another very important tool as far as location of the MB2 or any missed or extra anatomy for that matter is the CBCT. This case in particular was referred by a friend for location of an MB2 canal. The CBCT in cross-section very clearly shows us the presence of the MB2 and the location. So as far as MB2 canals are concerned, in case you are unsure about whether it is present or not or where to find it, never hesitate to take a cone beam CT. So these are the cross-sectional views. This is the frontal view of the same. And again, it clearly shows us the presence of more than just the MB canal on the mesiobuccal root of the maxillary first molar. Though this is all the pulse chamber had to offer in this case about where the MB2 canal was present, thanks to the CT that was taken prior, we knew exactly where to go ahead and locate the MB2 canal. This is the MB2 canal located and shaped, but sadly we could not finish this case because in the following visit the patient reported with a fractured palatal tooth structure. So this case was deemed unrestorable and we couldn't finish it. So here's a case that was referred to me for inability to locate a distobuccal canal. So we managed to find the distobuccal canal, which is a little behind the perforation that was accidentally made. And coming back to the topic of our interest, the MB2. So this was the clinical scenario on the mesial aspect of the tooth. The floor was a little gorged, showing no evidence of the MB2 canal. So as always, I troughed down, hoping to find the MB2 canal, and I still couldn't find any evidence of the MB2 canal. So what I've done here is, I've banked on what is called the centricity of the file in the IOPA. So in certain cases, when you're unsure whether you have an MB2 or not, what you can do is put a file in the existing MB canal and then take a well-angulated radiograph. If you find that this file is more or less in the center of the root and not leaning on towards one side, the chances that you have missed an MB2 canal are much lesser. These are not absolute rules, but then certain guidelines which we can go by as to whether or not there is an MB2 canal in a particular case. So that's the finished post-operative radiograph of this case. So here's another interesting case that I'm working on currently, a 2-7 that was referred for retreatment. So on the routine exploratory axis, I realized that a blob of composite has been kept on the location where you generally find the MB2 canals. We must remember that the maxillary second molars very routinely have these MB2 canals as well. What I missed out in the preoperative radiograph was that this tooth had a broken instrument in the MB2 canal. So what was done next is, the broken file was retrieved from the MB2 canal using ultrasonics. And once the broken file was removed, a good channel for the pus to drain out was created. And then in this case, we placed an internal drain for the lesion to decompress. And after the discharge completely stopped, we gave the patient a calcium hydroxide dressing. And as of now, we have kept him under observation. And once there is some evidence of the lesion healing, we would probably consider a obturation. And for those of you who might be interested in enhancing your microendodontic skills, we conduct broken file retrieval courses routinely in Bangalore. I will provide more details on the course in the following slides. Next is the part of the lecture where we discuss the different tools and techniques that will help us locate these MB2 canals. The first and most important prerequisite for location of these MB2 canals, calcifications or any extra anatomy is good magnification and proper isolation to give us a very crystal clear view. As far as magnifications are concerned, no doubt microscopes are the best. But if you use a good set of loupes, they just might be good enough as well. And in case you do not use either of the two I've mentioned, you just might fare better off referring the case to a colleague who uses them, rather than bringing the tooth to a point where it cannot be restored at all. So the next most important thing is the mirrors. Dentistry is almost entirely practiced in direct vision, so you see only as much as your mirror can reflect. It is a very, very wise thing to invest on a good set of mirrors. These are the ones I use in practice, but you do have other very good front surface mirrors as well. The next thing is a very sharp explorer. So let's just say you have this point in the axis where you have a doubt as to whether the MB2 is present there or not. You need a sharp explorer to scratch and look for the catch. So that's one very important requisite as well. The next most important thing you can invest on are the Munz burrs. These Munz burrs are nothing but long neck burrs which can be used to drill out calcifications, pores, and also to trough out these MB2 canals. These are not very commonly available in India. So alternatively, you might want to consider these Maysinger burrs. We get them a lot here, and these can be used interchangeably as well instead of the Munz burrs. Now a little about ultrasonics. How ultrasonics help us is that the amount of dentine removed when you use an ultrasonic is very much controlled. And the visibility when using an ultrasonic, when compared to using a slow speed handpiece or an aorta, is so much more higher. So especially when you're trying to locate and look at something, the extra visibility it offers is extremely handy. Next is the Stropco. Stropco is nothing but an extension that can be attached to the conventional three-way syringe. The added advantage is that it has a locking mechanism so that when you blow air through your three-way syringe, these little tips that are attached to it will not fly off. Additionally, your local mechanic can add an extra attachment to the chair which can help reduce the pressure of air that comes through the Stropco, meaning you can boldly use it into the pulp chamber and also inside the canal without fear of emphysema or any other complication. So when debris accumulate on the floor of the pulp chamber, the Stropco is a very essential aid which is going to help you blow out these debris and keep the area clean. So these Stropcos we've discussed are a little pricey, and in case you do not want to invest that much on a Stropco, these are a couple of products that I've actually come across online. I'm not too sure if they are as effective as the original one, but better than having nothing at all. And this is the tri-way adapter from the Ultradent, which I have not used but then can help the purpose. 17% liquid EDTA is one other thing which I use over and over again whenever I'm trying to look for anatomy. Whenever you have a pulp chamber that is filled with debris, all you need to do is leave a drop of liquid EDTA and scrub it well with these micro applicators. So the most important thing when you're trying to look for anatomy is to make sure the pulp chamber is squeaky clean so that you'll know exactly where you want to work, rather than having debris lie all over the place and blindly digging into different areas. One other important thing I'd like to say is, never try to gain the whole length of the MB2 canals with a hand file alone entirely. These MB2 canals have a very fine tortuous curvy course, so it is going to be difficult to get from point A to point B entirely with your hand files completely. What you need to do is use a rotary file to the depth to which your hand file goes, be it 4 or 5 millimeters, to open up the MB2 and gradually then advance with the hand file again. So what I'm doing here is I'm opening up the MB2 orifice with a 10-4% file. I'm a little aggressive here. I wouldn't really recommend a beginner to do the same because the chances of you ending up with an instrument separation are very high. Even I risk the same, but I'm quite comfortable removing these instruments if and when they break. So if it's a beginner watching, you'll have to be a little slower when you do this. One very essential part of our armamentarium that is often neglected as far as negotiation of the canals are concerned are the hand files. The conventional K files that we use are far too soft and will buckle when you try to negotiate an orifice that is blocked or a canal that is thin and tortuous. This is the D-finder from Mani. The D-shaped cross-section of this hand file makes it very stiff and will help you push through the orifice which is blocked. But I wouldn't really recommend using this beyond 3 to 4 millimeters into the orifice. The stiffness also makes it vulnerable for fractures. So this is one very important armamentarium which we need to have in case you're looking at negotiating those MB2 canals. One other file that I very routinely use and can do the job for us are the C pilots from VDW. The thermal hardening process that they undergo make them very stiff and can push through those blockages and also negotiate the tortuous canals all the way up. Another thing as far as hand files are concerned is never put a large hand file into an MB2 or the probable area where you think an MB2 is present straight up. Always use a smaller 8 or a 10 size file. A 6 size K file is far too soft to be used to negotiate a MB2 canal, so I wouldn't waste too many of those for sure. And another thing is, even if you're negotiating a tooth that is 26 or 27 millimeters long, always consider using a 21 mm file at least as far as you can go, because the longer the file is, the more the chance that it's going to bend and buckle. That is, when the distance between the point at which you apply the load and where you hold the file is far, lesser is the tactile sensation. So shorter files are any day better than longer files. And in case all you have is a 6K file to negotiate those MB2s, the chances that you will end up buckling the tip are very, very high. And if that happens, you really do not have to throw the file away. What you can do is just cut the first 1 or 2 millimeters with a scissor. So what happens here is, if you cut 1 millimeter or 2 millimeters, your soft 6 size file becomes a much stiffer 8 or a 10 size file, which is also shorter, which is a added benefit which can be reused, and you really don't have to waste these files at all. Another important thing that you need to have are the micro openers. The micro openers are nothing but hand files with a offset handle. The advantage is that these handles are at an angle, so when you use a conventional hand file and try to negotiate or locate a canal, your gloved finger comes right over the tooth and you cannot really see the tooth at all or the point of negotiation. But when you use a K file that is attached to a handle which is offset, you get complete visibility. The picture you're looking at here is not a micro opener but an Endo handle. This is what I use routinely in practice. The company called Venta Endo makes them. I think Zumax has one as well. The advantage of Venta Endo or these Endo handles when compared to the conventional micro openers is you can fix the conventional K files to these handles and reuse them over and over again. Though a little pricey initially, over the long run they work out very inexpensive because you can use them a number of times. This is just a product video from the company on how these endo handles work, just to give you an idea. So that's just the conventional K file, which is pre-bent with a plier. It's a very self-explanatory video. So you just open up, insert the file inside, and lock it back on. So as long as you don't lose the handle, you can keep reusing these handles infinitely. So far we have discussed on how to locate these canals and the necessary armamentarium. So now a few thoughts on how to instrument these canals. So when it comes to negotiating a MB2 canal with hand files, you always have to approach from a mesial angle with a pre-bent file. You can never do it with a straight file, because when you're directly under the orifice, it's going to take away most of your vision, one thing. And the next thing is, it needs more space. The mouth opening the patient gives you may not be enough for you to have a straight file right under the tooth. So what you have to do here is introduce a pre-curved file from a mesial angle. And once you have engaged the orifice, it may not be possible from this position to give the kind of control force you want to open up these orifices. So what you have to do here is, once you engage the orifice from the mesial angle, you need to distalize the file, as in move the file from a mesial angle to the distal and then start doing your watch winding motion. So here's a small video of me showing you how exactly it is done. So that's a small groove there where I hope to find my MB2 canal. I've introduced my D finder into that area. And now, as you can see, I am moving the hand file distally and then using a watch winding motion until I have managed to negotiate a few millimeters. Now I would go in with a rotary file, open up the orifice further, and then go ahead with my process. So that's the same case. All 4 canals located, obturated, and again this is a maxillary second molar, and these maxillary second molars do have these second mesiobuccal canals quite often as well. With this, we pretty much come to the end of the lecture, and I'd like to finish off by stressing on one point I always stress every time I lecture on endodontics. That is, remember, the teeth are very delicate structures, so don't enlarge them too much, a lot more than that is needed. This is one particular case where all 4 canals have been beautifully located, but then have been very aggressively instrumented with very large tapers, and there's a fracture in the mesiobuccal root. So as far as shaping these canals are concerned, especially when it comes to the MB2, remember it's a very fine tortuous anatomy. So you need to be a little thoughtful on the tapers and the sizes you'd like to use. We are endodontists and restorative dentists, and root canal is a procedure that is done hoping to preserve the teeth. So when you leave more of tooth structure, you preserve the tooth longer for sure.
And that brings us to the end of this lecture, and I hope you found it useful. In case you have any doubts or clarifications, you can always email me or even send a message on Facebook. I'm quite active on all these social platforms, and the details will follow in the subsequent slide. Hoping to see you soon.